even though we have completed these placental barriers or the remaining topics, let me take a brief introduction of these topics which we have already dealt with. Okay, because these are very important. So next one is the functions of placenta. We have already said the transfer hormone, how the hormones are being produced by the placenta and how it acts as a barrier and the immunological functions of placenta. Right? So, and the main thing though, the questions might be coming from these topic exactly. So the placental abnormalities. First one is placenta previa, which we have read in the which we have dealt in the previous class. So the placenta previa is nothing but the low-lying placenta. When the placenta is lying the lower portion of the uterus, which is known as placenta. In major cases, it will be covering the internal osses. So the according to the degree of the coverage of the internal os, the placenta previa has been classified as to type 1, type 2, type 3, and type 4. As you can see in the type 1, the lower lying placenta will be just covering the only 1 by 4 portion of the internal os, whereas in the second type of placenta previa, nearly half of the portion of the internal os is covered with the placenta, and in the third, majority of the internal os is covered, whereas in the fourth type 4 placental previa, the entire internal os is covered. So please look into the picture and understand the situation. So in the placenta, what is the main causage of placenta previa? It is because of the disturbance in the zona pellucida covering. So when the zona pellucida covering is not appropriately peeled off as such, when it enters into the body of the uterus, when it is not peeled off that the adequate time, and that is in the anterior upper part of the uterus, there is a downward dropping theory of the placenta. The zona pellucida will be or the what are the formed blastocyst will be dropped down towards the lower portion of the uterus. So when the what when the zona pellucida or the blastocyst is lowered down to the lower portion of the uterus, and when the zona pellucida layer is removed, then it will start attaching to the area which it got. So that's why the in the lower lying placenta or in the lower portion of the uterus, the baby or the decidua starts to grow. So that is a condition of placental abnormalities, and we have seen. See, placenta previa and abruptio placenta, the major complications which can be seen in the obstetric emergency. So this is very important, and you might get questions either from placenta previa or from abruptio placenta. This is for sure. Okay, bleeding disorder. You will be getting a question from bleeding disorders of pregnancy. This obstetric emergencies. So either it might be from placenta previa or from abruptio placenta. If none of the questions have been asked from either of the portions, then you will get a question from ectopic pregnancy. So the symptoms, that is the bleeding throughout the pregnancy and during the delivery also. And we have said the placenta previa is not having pain, that is painless bleeding will be there. And how will you diagnose it? So you can, placenta previa is usually discovered after a woman experiences bright red vaginal bleeding, that is without pain. That is the main indicator, main the distribution factor here. There won't be pain when there is a bleeding. And during the second half of pregnancy, and some women have contractions also, that is Braxton Hicks contraction. So what you have to do, your obstetric team, which means doctor and the nurse, have to arrange an ultrasound to confirm the diagnosis. That is a diagnostic modality. So how the treatment lies: to limit bleeding during the pregnancy, avoid activities that might cause contractions, including having sex. So that including having sex. So when you are diagnosed to have placenta previa, it is better to avoid sex, or that, or you have to modify the positions of the patterns of the sex in such a way that the thrust is not directly affecting on the womb. Okay, so we can see, actually in the modern studies we can't say you have to avoid sex, but you have to modify the positions of the sex so that the male thrust is not directly applied on the what the womb, or it might not start bleeding the placenta previa portion. Then using tamponade, douching, or engaging in activities that can increase your risk of bleeding, such as running, squatting, and jumping. Are you hearing any disturbance in the line? Hello?
Yes, yes.
So as a treatment, see, the main treatment is that you have to continue the pregnancy until the placenta previa is not complicated. Like, for example, it should not lead to bleeding. So that so the treatment is bed rest. Okay, fine, finally it's bed rest. And then so the placental inversion. See, these are the normal. Am I audible? Hello,
Yes,
am
sir.
I audible? Okay, fine. So the placental inversion, how the placenta is inverting. See, you can see my cursor, right? So see, this is a normal amniotic fluid, and this is a normal myometrium of the uterus. So the placenta won't be involving in too much, or it won't go into the deeper portions of the myometrium. Okay, it will be just holding. The placenta will just holding to the uterine cavity. So this is a normal condition. So what in here, what is happening in placenta excreta? See, the depth or the involvement of the placenta into the myometrium is increasing. See, in excreta, increta, and percreta. So the level of penetration into the myometrium is increasing in these three different cases. So what is placenta excreta? So the placenta excreta occurs when the placenta attached too deep in the uterine wall, but it does not penetrate the uterine muscle. So this is the main difference. See, in the placenta excreta, even though it is involving into the deep, it is going deep into the uterine cavity. It is not for penetrating the uterine muscles. Okay, with placental excreta, part or all the placental remains attached, which can cause severe blood loss after delivery. Why? Because we have to remove the placenta. So when the placenta is being removed, the underlying tissues is having a steady connection to the uterine wall. So when it is being removed from the body, see why it is having a steady connection with the uterine wall. Its connection is with the blood vessels also. So the blood vessel will be tagged off, and it leads to severe bleeding. And what are the symptoms of, see, the placental excreta also, the main symptoms is that it leads to bleeding. Okay, so placenta excreta is having no signs and symptoms during pregnancy. Okay, so the only sign and symptoms which show the placenta previa is showing is that it will be having what bleeding, which is non-painful. So although the vaginal bleeding might be there in case of third trimester, and how you can diagnose it? It's simply with ultrasound. And what is placenta increta and percreta? See, it occurs when the placenta grows at least halfway through the walls of the uterus and attached itself with the uterine muscles. Okay, so what is the main difference is that even though in case of excreta it reaches the placental muscles, or it won't cross the placenta, it won't cross the placental muscle. Okay, so in case of placenta increta as well as percreta, it will cross the placenta, it will cross the uterine muscle, and it have a strong grip over the uterine muscles. So the symptoms, it is often also no symptoms are there, though vaginal bleeding is present, and it can be diagnosed with ultrasound and MRI. See, MRI is not at all needed because when doing ultrasound itself, you can identify that. Next is, we have already said all these conditions, right? Circumvallate placenta. So circumvallate placenta, what is circumvallate placenta? It occurs in the amnion as well as the chorion fetal membrane of placenta, which means it is having an succingerate plate. Okay, that is circumvallate placenta. So we have said all these things: fetal membranes, what is amnion, what is chorion, what are the amniotic fluid, what are its abnormalities. So, Shiny, could you please guide me if the amniotic fluid is seen in golden brown color? What is the condition? Shiny, hello.
Hello.
Yeah. What is the
Hi, sir.
condition? What is the condition when the amniotic fluid is golden brown in color? Oh, golden color. If your amniotic fluid is golden in color. Okay. What about if it is coffee brown in color? I think we have discussed all those things, right?
I see it.
Jyoti, could you please guide me? Hello, Jyoti.
Yes, sir.
Yeah. So, what is your amniotic fluid? Is what will be the color of the amniotic fluid if it is post maturity? Guys, I think I have discussed all these things. Green in meconium aspiration, didn't I? Pea soup color in chronic fetal distress, golden color in RH incompatibility, then greenish yellow color or saffron color in post maturity, dark color in concealed hemorrhage, whereas dark brown or juicy tobacco juice. What what you can see in tobacco juice? What is the condition that predisposes tobacco juice color?
ICD.
Yeah, it's IUD. Okay. Guys, you are not at all studying. Next the next umbilical cord also we have discussed two arteries and one vein is the structure, length, and all those things, and conditions like velamentous placenta. What is see what is the normal umbilical cord insertion? How it has been inserted? See, it is inserted in the center of the placenta, whereas velamentous placenta it is in the edge of the placenta. So battledore placenta. The umbilical cord is attached to the placental margin. See, you can see the pictures. It is attached to the placental margin. See, it is attached to the in case of normal condition, it is attached to the center. Whereas in case of battledore placenta or velamentous mainly, the placental margin, the cord is attached. So vasa previa. What is vasa previa? The presenting part will be the umbilical cord. Okay, that is vasa previa. The presenting part will be the umbilical cord. Next is the obstetric pharmacology. So first obstetric pharmacology or the first medicine. Before moving into obstetric pharmacology, let me complete the exchange transfusion. Guys, please write down what are the indications of exchange transfusion. What are the indications of exchange transfusion? Minu, what are the indications for exchange transfusion? I'm talking about the neonate, okay?
So,
So the indication for exchange transfusion for a neonate is that HB is less than 11 mg per deciliter and the cord blood bilirubin, okay, it is greater than 4 mg per deciliter and rising bilirubin over 1 mg per deciliter irrespective or despite of phototherapy. Even though we are giving phototherapy to the baby, the bilirubin level is rising over 1 mg per deciliter per hour. In an hour, if the bilirubin level is increasing more than 1 mg per deciliter, we have to start the phototherapy. We have to start the exchange transfusion. So the cord blood bilirubin is greater than 4 mg per deciliter. Okay, and also RH positive with direct. Please underline this: RH positive with direct Coombs test positive babies. If the baby's Coombs test is positive, and if the baby is RH positive also. Clear. So what is the amount of fluid that we'll give? It is 160 ml per kg. Okay. Yes, what is Coombs test? See, Coombs test, COOMPS, Coombs test is otherwise known as anti-globulin test. Okay. So it is either of blood test used for the immunohepatology. There are two types of Coombs test: direct Coombs test and indirect Coombs test. Okay. So actually the Coombs test detects the antibodies that stuck to the surface of the red blood cell. The antibodies which is stuck to the red blood cells. So that the Coombs test will identify that antibody. That is the direct Coombs test. Then what? So which is the vein that we are selecting for exchange transfusion? Is it a brachial vein or a superficial vein? Cephalic vein? Which vein? Which vein will you select to start the exchange transfusion to the baby? Shiny, which vein?
Umbilical cord, sir.
Yeah, very good, Munira. It's umbilical cord, mainly umbilical vein. We'll start the exchange transfusion in the umbilical vein. Okay, so what is push-pull method? We'll start the exchange transfusion as push-pull method. What is push-pull method? Munira, what is push-pull method?
Push-pull method, sir.
Yes. For example, if you have to, for example, the baby is of 3 kg. Okay, so the amount of transfusion is 160. You can identify it's 150 ml for the better understanding or better remembrance. For 150 ml per kg. So total as a total, we have to exchange or you have to transfuse the baby around 500 450 ml. Clear? So how will you administer the 450 ml? So we will administer the 450 ml in 3 or 4 consecutive periods. Like for example, if you will you will administer 50 ml, then you will retract the 25 ml again. Then you will identify 50 ml, then 25 ml. You will retract the 25 ml from the umbilical vein. Then again you will administer the 50 ml. So this is known as push-pull method. Okay. So, and one more thing, please underline. After each 100 ml of blood is given, we'll give soda bicarbonate. Okay. That is given to prevent the metabolic acidosis. Okay. So, ഓരോ 100 ml blood identify കൊടുത്തതിന് ശേഷവും we will give 1 ml soda bicarbonate. For each 100 ml, for each 100 ml blood for which we are giving, we'll administer 1 ml soda bicarbonate to prevent metabolic acidosis. For example, if you are giving 400 ml, then you'll give 4 ml of soda bicarbonate. Okay. Then we have something known as malpositions or malpresentation. So malpositions or malpresentations can be divided into 1, 2, 3, 4, 5, 6, 7. Okay, on a 6, 7 scale basis. Okay, so first malposition may be occiput or posterior position. Second is deep transverse arrest. Third one is breech position. The breech position we have to focus. Okay, others you just leave. So breech position, there are how many types of breech positions are there? So the main breech position is breech that is flexed breech, or normal breech. Okay, flexed breech, which is known as complete breech. The second one is breech with extended leg. The baby is be in the breech position also, and the leg will be extended. That is known as flank breech. Third is footling presentation. Footling presentation means foot will be the presenting part. Those are the 3 types of breech presentation. And what are the complications of breech presentation? There will be increased IC hemorrhage. Okay, intracranial hemorrhage, there is complications of intracranial hemorrhage will be the asphyxia. Okay, asphyxia, fracture, then Erb's palsy. So how will you take the delivery of the breech baby? It's nothing but by doing Burn Marshall method. So what we are doing in the Burn Marshall method is that we'll simply let the baby to hang by its own weight. That is Burn Marshall method. Then we'll take the malar flexion of that. And second is the Pinard's maneuver for flank breech. Then Lowset maneuver for arrested pregnant after coming off the head. So when the head for arrested after coming off the bed. So for example, we said the breech as well as the leg will be out of the pelvic cavity, but the head will be inside the pelvic cavity. So in that condition, we will apply the low set maneuver, LOB-SET. You just identify these maneuvers. Low set maneuver if in case of head is arrested inside the pelvis, whereas the other part of the body is outside the pelvis or outside the mother's body. Second maneuver is Pinard's maneuver, PINARTS, Pinard's maneuver, which is given for flank breech. And the third one is Burn Marshall method. In the Burn Marshall method, we'll simply let the body to hang through out of the vaginal wall. So due to the weight of the body of the baby, the delivery happens. Clear? And the other malpresentations are transverse lie, unstable lie, compound presentation, and cord cross lie. See, in nowadays, if all these malpositions are happening, we'll literally go to cesarean section. Okay. And one more thing which we have to focus is PPH, postpartum hemorrhage. Okay. The remaining complication in the third stage of labor. Bleeding condition, postpartum hemorrhage. So the postpartum hemorrhage is mainly divided into primary postpartum hemorrhage and secondary postpartum hemorrhage. What are the causes of primary postpartum hemorrhage? The first cause of postpartum hemorrhage, primary postpartum hemorrhage, is atonicity of the uterus. Okay, uterus won't contract after that. So the placenta will be attached to the uterus itself. The uterus won't be contracting. The atonicity of the uterus. So in case of grand multipara, if the mother is have given more births to the baby, so grand multipara. Then over distension of the uterus, antepartum hemorrhage. If the mother had any antepartum hemorrhage, prolonged labor. If she had continued the labor for 12 hours or more, prolonged labor. Then any fibroid in the uterus, constriction ring, uterine constriction ring. So those are the conditions that causes atonicity of the uterus. That is the one cause of postpartum hemorrhage. Guys, I think you all are writing the notes, right? The second one is traumatic causes. So traumatic causes, for example, if any injuries happen to the uterus, for example, it was a previous serious condition. So when we have done the vaginal delivery, due to the previous trauma, there might be atonicity of the uterus or any physical trauma to the uterus. Third one is blood coagulation. So the conditions like abruptio placenta, HELP syndrome we have discussed yesterday, HELP syndrome, then blood dyskaryosis. So in all those conditions, there is a chance for postpartum hemorrhage. That is a primary postpartum hemorrhage. Next is the secondary postpartum hemorrhage. That is bleeding between 8 to 14 days of delivery. Okay, bleeding between 8 to 14 days of delivery. So that is caused due to retained bits of placenta inside the uterus, or due to subinvolution of the uterus, or due to polyps in the uterus. Okay. So next is the pharmacological or obstetric pharmacology. The first drug which we are using is oxytocin. Oxytocin, how the oxytocin is functioning? The calcium channels to initiate myometrium contraction. Okay, it increases the influx of calcium to the myometrium. So that the myometrium or the uterine muscles contract. It also stimulates amniotic and decidual prostaglandin production. Okay, we have seen how the mechanism of action of oxytocin is taking place. Okay, so once again, we are just brushing it. It increases the influx of calcium and also it stimulates the amniotic and decidual prostaglandins production so as the contraction increases. What are the indications of oxytocin? So in pregnancy, so we can divide the pregnancy into late pregnancy and early pregnancy. So why we are giving in the oxytocin for the early pregnancy condition is that to increase the abortion and to stop bleeding. Okay, that is the indication for early pregnancy conditions that in which we are giving oxytocin. It increases the abortion and to stop bleeding. And in case of late pregnancy, it is given for cervical ripening and induced labor. Okay, so we'll be the patient will be in Pictoxin drip or oxytocin drip. Why? It's to induce the labor and for the cervical ripening. What are the contraindications? What are the contraindications of this oxytocin? The main contraindication is hypovolemia. There will be hypovolemia. Then cardiac diseases. Then grand multiparous women. Then contracted pelvis, cephalopelvic disproportion, and history of CS, history of early CS, malpresentations, obstetric labor, fetal distress. All these conditions are contraindicated for oxytocin. Okay, why? Because it will directly affect the baby. Cardiac disease will affect the mother as well as the baby. If the mother is affected, definitely the baby is affected. What are the complications? So the maternal complication is uterine rupture, then water intoxication, hypotension will be there, and uterine hyperstimulations. So those are the complications of the maternal side complications. The uterine rupture will be the water intoxication, hypotension, and uterine hyperstimulation will be there. Then in what about the fetal condition? So there shall be fetal distress. Okay, there shall be fetal distress. Okay, fine. So next, second medicine is ergot derivatives. For example, ergometrin, then methergin. Simply our methergin, that is ergot derivative. Methergin. So the methergin acts directly on the myometrin. Okay. Clear, the methergin will act directly on the myometrin and it stops bleeding following the delivery. So soon after the delivery, we'll administer the methergin, right? So it will help the crisscross mechanism of the muscles. It increases the crisscross mechanism of the muscles and decreases the bleeding. So what is the contraindications of giving this methergin in case of organic cardiac conditions and severe pre-eclamptic stage and RS negative mother? Okay, that is a contraindication. Please underline these things. Okay, cardiac diseases, organic cardiac diseases, severe pre-eclamptic conditions, and RS negative mother. RS negative mother means there is a chance of erythroblastosis fetalis for the next baby. That is the reason. The third medicine is prostaglandin. So, example, give me an example. So, prostaglandin E2 and prostaglandin F2 alpha. That is misoprostol. Mifepristone and misoprostol. That is prostaglandin. So, it is given to induce abortions like and termination of molar pregnancies, cervical ripening, etc. Okay. Then what? So contraceptives. So there are questions asking on the basis of contraception. So what are the permanent methods? What are the what are the temporary methods which we are using? So see, mainly it is not natural method. It is mainly contraceptives are divided into permanent as well as temporary. The natural method comes in the temporary method. Okay. So, for example, in temporary method, barrier method is that. In the barrier method itself, mechanical, chemical, physical methods. So, the first physical barrier method is that coitus interruptus or abstinence from the sex, no sex. Coitus interruptus means without ejaculating the semen inside the vagina. That is coitus interruptus. But it is not at all a healthier condition, whereas the pre-coitus fluid also contains more than 50% of semen. So that is not a good way of contraception. Then mechanical means a barrier is keeping, right? For example, condoms, diaphragms, cervical caps, vaginal female vaginal condoms, etc. Then chemical methods like creams, jellies. There is swabs, sponges are there. Then what? And for example, to add into the natural rhythm, into the natural method, there is rhythm method. Okay, rhythm method means the calendar method, which is also is not a good option. Then breastfeeding. So breastfeeding mothers are herself having the contraceptive method, but even though it's said as a barrier method, it is not at all a contraceptive method. Then what? What are the permanence methods? There are only two permanent methods. Which are they? They are sterilization, vasectomy, and tubectomy. So those are the two sterilization methods. Then comes our intrauterine devices. So intrauterine devices means copper T, Lippes loop, etc. So what are the complications of copper T? Since it is copper, there is chance of developing what copper related diseases in the uterus. So it is better to go with Lippes loop when compared to copper T. Otherwise, copper T is safe and effective method. Then that like steroid contraceptions are that is pre-pill and post-pill. You know, pre-pill like Maladi is an example for pre-pill, and post-pill is I-pill. Okay, so it will change the the progesterone and estrogen hormone variation, and it will prevent from what fertilization. Okay, so in pre what happens? It prevents the fertilization, whereas in post condition it will prevent the implantation. Okay. So thus we are coming to the end of this obstetric. So do you have any doubt on that? So we have come. I think this was a huge. We have continued up to 9 to 10 classes for this obstetrics, right? So thus we have completed that. If you have any doubt in obstetrics, please let me know. Okay, so those who haven't attended the class, I'll send the recorded versions. You please study these things. If you have any doubt, please ask me. And one more thing, we are for the batch which we have started earlier, we are going to end these sessions. So let me say you one thing frankly, that we have some short questions with the prometric exam of the Saudi Arabia. So I wish all of you must attend the session. Definitely, you must attend the sessions in which we are going to provide you the short questions of prometric exams. Okay, so please don't miss all those classes. So before, there are approximately 1,000 questions which the agents had given to us. But meanwhile, what you have to do is that you have to by heart all those 1,000 questions. Then in under that you will definitely get the questions from the for the prometric exam. Okay, so that is one method. So even though you have when you have to study those 1,000 questions, uh, to understand those 1,000 questions, you must study well the topics which we have taken. Okay, if you are correctly and completely continuing the classes which we are taking and the PDFs which we have given and the questions, I must assure that the previous questions which we have, which we dealt with, then definitely you will pass the prometric exam. Okay, so guys, ending the session. So if you have any doubt, if you are not comfortable in talking into a public space, you can personally chat with me. Okay,
So when you'll send the questions,
pardon.
सिर्फ questions जो आप बोल रहे हैं 1,000 questions तो